take a deeper look at a CoreLink FlexFit implantation. First, a discectomy is performed to remove the diseased or damaged intervertebral disc, and the space is prepared for the device. The appropriate implant size is determined via trialing. This posterior lumbar fusion device is inserted and expands up to 15 degrees to restore lordosis, which is the natural curve of the spine. This is intended to be used with supplemental posterior fixation.
Welcome everybody to the Restoring Lumbar Lordosis with an Expandable and Articulating Interbody Masterclass with a truly exceptional presenter. Dr. Mark Weinstein will discuss 2-year clinical and radiographic outcomes of a prospective study of segmental lordosis and fusion with the CoreLink FlexFit 15 Interbody. But first, I'd like to introduce our moderator for this evening, Adam McMillan, to give a little background on our topic today. Adam has spent his entire career developing spine and orthopedic medical devices and biomaterials. He has a passion for innovative design, additive manufacturing, and nanotechnology. He currently oversees new product development as Vice President of Marketing at CoreLink.
Thank you, David, and thank you to all of our attendees today. CoreLink is a spinal system manufacturer based here in St. Louis, Missouri, where we design, develop, and manufacture over 99% of our portfolio, including the FlexFit 15 device, which is the topic of our discussion today. FlexFit 15 is an articulating and expandable interbody fusion device that allows for controlled and continuous expansion up to 15 degrees and creates up to 4 millimeters of height restoration. I'm honored to introduce Dr. Mark Weinstein, who's been using the FlexFit 15 device now for over 4 years. He's a board-certified orthopedic surgeon who's dual fellowship trained in both spine surgery and biologics. He holds a position as an assistant professor of sports medicine and orthopedics at the University of South Florida. So thank you for being here, Dr. Weinstein, to discuss your prospective study results today.
Thank you, Adam. It's a pleasure to be here today, and thank you to the audience for allowing me to present our experience and results using the FlexFit device. I don't have any disclosures other than the research support by CoreLink. So why do we use cages in spinal fusion? Well, we're all familiar with cages, and they've been pretty much commonplace now in spinal fusion. They tend to enhance segmental stability, which leads to the promotion of solid fusion. They help us maintain neuroforaminal disc height and decompression, and they allow us to achieve improved segmental lordosis and sagittal balance. It is this aspect that we wanted to study a little bit in more detail, as it is a concept that's a little newer to us as spinal surgeons for degenerative disease. It's well known that, at least in scoliosis surgery, that sagittal plane balance is very important in terms of long-term outcomes, and that spinal pelvic parameters play a role in determining outcome and disability. In both surgical and non-surgical patients, it's been shown nicely that sagittal balance and spinal pelvic parameters correlate quite significantly with disability. We also are learning more that this segmental balance and spinal pelvic parameters play a role in degenerative spine disease as well. And even in short segment fusions, it can turn out that hypolordotic fusions wind up leading to hyperlordosis at the adjacent level. We see this clinically in patients who have relatively some ability to compensate for their hypolordosis preoperatively, but when fused in hypolordosis, wind up getting adjacent segment hyperlordosis and adjacent segment changes. Again, this is borne out in some of the patients we have seen in our office as well. They're fused hypolordotically, and the adjacent segment has some retrolesthesis and results in hyperlordosis to compensate. We know that most of the lumbar lordosis occurs approximately 2/3 of the lumbar lordosis occurs from L4 to S1, and that the compensation can occur more cephalad, And we see this naturally in patients. The most important levels and the most common levels for degenerative fusions happen to be also between L4 and S1. Therefore, it's important to get these levels right. And when we do fusions for single level disease, it's actually been shown now that as we wind up with more and more pelvic mismatch in terms of the pelvic incidence and lumbar lordosis, surgery for adjacent segment disease tends to increase. And this also is valid also for outcome studies, including back pain and leg pain, which often tends to do worse in patients who have pelvic mismatch after short segment fusions. We can see an example from my early years. A patient was fused with a TLIF, relatively hypolordotic, but after 2 years still has the ability to maintain hyperlordosis at these superadjacent segments and able to compensate. This slowly then deteriorates over time. Patients lose the ability to compensate, they develop adjacent segment disease, and ultimately it's an intolerable problem and they wind up asking for surgery. Dr. Uribe did a nice study in which she looked at degenerative spinal fusions and noticed that while patients often start aligned, end up aligned, there is a proportion of patients that start aligned and end up malaligned, and even more so start malaligned and wind up not being corrected, losing the ability to help the patient in the long term with improving the sagittal balance during the degenerative fusion. So for a poll, this will be the first poll question. When I perform interbody fusions from a posterior approach, I most commonly use A, static cages that are straight, B, static banana-shaped cages, C, straight expandable cages, D, banana-shaped expandable cages, or E, other. So when we look at degenerative fusions, some have wondered, are these cages themselves somehow leading to kyphosis? Are the cages kyphogenic? In the past, in the history, most cages were box-shaped, and this could lead to increases in peaks and constraint on the end plates. We've seen studies of at least minimally invasive transforaminal lumbar interbody fusions that really have not provided very impressive improvement in segmental lordosis, and in some cases, even loss of segmental lordosis. That lends us to then question whether it's the TLIF itself that is the kyphogenic problem. Well, it's been shown, especially in Dr. Shaffrey's hands, that TLIFs themselves are not kyphogenic, and when performed meticulously and properly, excellent restoration of sagittal lordosis can be achieved. And you can see that here, and when you look at his data. Dr. Shaffrey then proposed some pointers on how to achieve segmental lordosis through the TLIF approach. And the important parts that he brought up is that, number one, you have to think about alignment. You can't be a degenerative surgeon not focusing on sagittal balance. Oftentimes, bilateral facetectomies are helpful during the TLIF to help obtain correction. Placement of the cage anteriorly, and then the cage type would be important for the recreation of lordosis with the transforaminal lumbar interbody fusion. So what are the benefits of expandable cage technology? Well, when we first started looking at these, a lot of these were potential benefits, but we now see that these are certainly beneficial. And one, that they can improve disc height, neuroforaminal volume. They can preserve the end plate integrity, so there's less damage to the end plates during surgery. We can decrease neurologic injury during insertion of the cages. We can maintain or even enhance segmental alignment, reduce the risk of expulsion posteriorly of the cage, and perhaps reduce operative time. When thinking about the ideal expandable cage, I think it's good to look for a cage that has a large range of expansion, so it can go in very small into the disc and then be expanded to a variety of disc heights. There should be, or at least oftentimes we'd like some area within the cage to accommodate graft material, although most of the graft material winds up getting packed around the cage in a good fusion. Lordotic expansion of the cage, we think, is paramount. Cages that can go in very small can reduce impaction force. Many of these cages allow us to improve our MIS technique, in which we can use the cage to help recreate the segmental lordosis. The ability of the cage to be collapsed and then removed or repositioned if necessary should be important. And then we would like cages that can accommodate a variety of interdiscal anatomy. So we would ask in a second poll question, when choosing an expandable interbody device, what is the most important consideration for you? Is it A, a banana shape, B, a straight shape, C, the ability to expand in lordosis, D, a graft window capable of being packed with bone graft, E, a backfillable, capable graftable cage, F, a cage that has surface technology to promote fusion, G, a cage that has a large minimal to maximal height expansion, or H, a cage that is mainly designed for minimally invasive approaches. So one of the classic examples of why expandable cages can be important is the fish mouth disc space, which is somewhat difficult to place a cage in which it has a very large open disc height in the front and small in the back. Expandable cages tend to be a nice fit in that case. There have been studies that looked at placing expandable cages, since they can be placed inside the disc space, collapsed, which leads to decreased work of impaction. And that's been shown in this study. It's also been shown that the expandable cage, in addition to Smith-Peterson osteotomies, wind up resulting in better restoration of sagittal alignment with either one of those techniques alone, and also better than using a static cage. We know that the shape of these static cages are also helpful in recreating segmental lordosis, and that rectangular cages tend to have much less change in segmental lordosis than wedge-shaped cages. And most importantly, especially in revision and collapsed spines, the space available to place the cage is in quite an expensive real estate area in which there are nerves, and in revision cases, things tend to be stuck together. This requires nerve retraction and root retraction, which can result in injury to nerve roots and the dural sac. So the idea would be to place a cage into the intervertebral space, in which the cage can go in small and help us with lordosis. On the left side, you can see what would be a representation of a static straight cage, and on the right side would be a lordotic cage. The real question would be then, how do we place a lordotic cage into a rectangular shaped disc space? One of the early ways we used to do this was with rotatable cages, in which cages would be placed from a posterior approach with minimal nerve retraction, and then rotated, allowing a lordotic expansion within the disc. And we used to do this with all kinds of cages. And in my experience, I did these with ramp bone grafts, and it worked quite well. It's just that when you needed large intervertebral disc heights, the cage had to be wide on insertion, again requiring significant neural retraction, especially in revision type cases. Another intriguing early design was repurposing the use of a vertebroplasty type device, in which the expandable mesh was filled with allograft while in the intervertebral space, and then expanded. And this was studied at least in cadaveric specimens. However, you can see that at least in this study, the increased disc height was quite minimal, and there really wasn't much increase in lordosis. This was used and still is used today clinically, in which patients have good clinical results. However, It's not quite satisfactory when looking at attempt to increase lordosis. Also, biomechanically, it's not quite satisfactory as the mesh is placed in the part of the end plate that is least able to withstand loads of expansion. You see this also with very small transversely placed interbody cages. The apophyseal ring would be a much better place for devices, and those who do lots of lateral body fusions understand this concept well. So over the years, there's been the development of expandable cages, many different types, and there's many different more than on this sheet here. They come in variable sizes, shapes, ability to expand, ability to be unexpanded, made with different technologies, PEEK, and titanium. The real question, however, is will expandable cages really aid in the maintenance and or restoration of segmental lordosis and then ultimately global lordosis? Will expandable cages help MIS surgeons? And I think from a small portal of entry standpoint, that will certainly be yes, but will it help them recreate lordosis in a minimally invasive aspect, I think is yet to be seen. And then what kind of cage configuration is best? So I would, at this point, ask the poll question number 3. Do you believe that expandable straight cages provide the same biomechanical benefits as expandable curved or banana cages? A yes, B no, or C unsure. Well, we have some evidence of cages, and expandable straight cages have been used for quite some time. You can see this study from 2016, which had fairly decent results from a clinical standpoint, also good results in increasing the disc height. However, even when you look at the author's own data, they really got very little increase in lordosis from a segmental approach using these transverse cages. When we look at minimally invasive transforaminal interbody fusions, with expandable cages. In this case, it was an expandable articulated cage. These authors found less than 5 degrees of increasement in segmental lordosis from a minimally invasive standpoint. When compared to a static cage in a minimally invasive setting, the expandable cage did much better in terms of disc height restoration and segmental lordosis restoration. In fact, significantly better results with the expandable cage. And you can see that in graphical format. However, looking at these 3 devices all together in one study, 2-year follow-up showed really a very little focal increase in the Cobb angle or the segmental lordosis after use of these cages when placed. And then finally, comparing a transforaminal interbody fusion with banana versus straight cages, there was some slight increase significantly in disc height with the banana-shaped cage, but in this particular cage, there was no real change in segmental lordosis. And this final study here looked at expandable versus static cages for transforaminal interbody fusion, and really didn't find much of a difference between the two. But it really, in this study, they didn't find much difference with any cage from a posterior approach, and really didn't get much in terms of segmental lordosis. This study looked at unilateral facetectomy, but used multiple oblique straight cages within the disc space. So when looking at the type of cage and why we would try to consider one versus the other, we could start with an example at the top left here, in which a straight cage is placed either posterior direct or posterior oblique into the interbody space and placed as far out front as possible. And then screws and rods are placed with compression. And you can see how in a straight cage, there would be fairly minimal end plate contact, but most of it would occur posteriorly, possibly damaging the end plates. In the middle example, we can try to place a lordotic cage into this space, And oftentimes, to create a lot of lordosis, we use a larger cage, which tends to damage the end plates on impaction. The idea might be to, as illustrated here in the bottom left, to place a straight cage, either again, a straight expandable cage, either again, direct posterior or obliquely. But you can see as it's expanded, there's not much room to compress posteriorly. We see this a lot with the straight cages placed obliquely expandable. These cages usually measure around 26 to 28 degrees and not much ability to compress posteriorly. So if you look at on the right, the idea would be to place a cage in small and straight in a small space and then expand it lordotically within the disc space, allowing segmental lordosis, either correction or maintenance. These are some examples of T-lifts that resulted in hypolordosis after surgery. In this case here, you can see what we see very commonly with these single cages placed in a minimally invasive fashion. Again, they're placed quite dorsal, not much room for compression and restoration of lordosis. Here, patient came in relatively hypodolic through the most important L4 through S1 segments, developed adjacent segment disease with some retrolisthesis at the L3-4 level and stenosis. A cage was placed, again, a single obliquely placed cage, quite posterior and flat, and ultimately resulted in even less lordosis than the patient started with. So to address this problem, at least from a biomechanical intellectual standpoint, we felt that a banana-shaped cage that provided lordotic expansion that could be placed anteriorly along the ring apophysis would provide some of the would provide more advantages in some of the shortfalls that we've discussed. This particular cage is FlexFit 15, is a slight modification of an original FlexFit 10, 10 being the degrees and 15 also being degrees of total expansion. This can be placed either open or MIS. It's titanium and it's articulated. It allows up to 4 degrees of expansion. 4 millimeters of expansion in the interbody space and up to 15 degrees. The expansion is controlled and continuous, and it also can be let down in a controlled and continuous fashion. It's articulated, allowing us to place it well across the midline and then create an articulation to push the case anteriorly. It has quite a definitive large footprint. The two sizes would be 32 and 40 millimeters. So the 40 millimeter cage often stretches quite well across the disc space. And it has, of course, a self-distracting bulleted tip. And you can see some of the features of this cage here. Again, the cage, the 40 millimeter length cage can expand 15 degrees and 4 millimeters height. The 32 millimeter cage can expand 3 millimeters in height. Again, one of the most important parts of the surgery, at least when we're doing surgery, we do tend to do a lot of revision and degenerative deformity work, is we tend to take down the facets. When we're doing open cases, we'll always do a bilateral facetectomy. The preparation of disc space is paramount, and meticulous discectomy is always performed. We feel we have to do a near complete and total discectomy when possible, which should be almost always. We used curved devices, curved kerosins, curved pituitaries. We prepare the end plates with osteotomes and a rasp. And then here you can see us placing with a funnel. We place bone graft anterior in the disc space before placement of the cage. For the FlexFit cage, oftentimes, if you pack the disc space with a lot of bone graft, sometimes you might choose to use a trial More recently, we've abandoned the trial and feel that we can achieve what we need to without a trial. But you can see that the cage will be placed into the interbody space, and then we can articulate that cage so that it sits in a nice banana shape along as far anteriorly and along the more structurally sound portions of the end plate as possible. We can pack the cage with bone graft, although we certainly feel that the most important part is the bone graft that we place around the cage, since we get much larger volumes there. You can see us placing the cage into the interbody space. Once the cage is in place, we place this device here, and we then expand the cage. We like to do this with occasional fluoroscopic imaging to ensure that we're not impacting the cage into the end plates, which again, given the anterior placement of the cage, occurs quite infrequently. Again, here's a simulation of what the cage looks like in situ and on X-ray. And finally, we take additional bone graft and then pack it into the dorsal aspect of the cage for final grafting. Here on top, you can see the cage being placed and articulated anteriorly and turned. And in the bottom image, you can see expanding the cage, which helps elevate both the interbody space, but the lordosis is also created as well. Here you can see how once the cage goes in and expanded, we create lordosis and elevate the end plates quite nicely. Again, yet another example here, patient who had multiple interbody cages. You can see all of them significantly helping us create lordosis in this patient. And again, the 40 millimeter cage provides quite significant coverage throughout the disc, and you can see the good results that this patient achieved. Again, here at L5S1, very collapsed space, able to again put in a small cage and help create lordosis with interbody expansion. And finally here, in this case, revising a fairly hypolordotic spine, trying to create a little bit more lordosis at the L2-3 segment. So same in this patient, again, who had adjacent segment disease. Patient had a flex fit cage placed, recreated lordosis nicely. However, ultimately went on to adjacent segment disease again. However, this allowed us to further image that cage, and we can see that the patients have good interbody fusion through the cage. We can look on our CT scan and see growth not only through the cage, but around the cage. Again, here's another example of that bone growth through the cage. Again, another patient with placement of the FlexFit device and excellent expansion. So poll question number 4 is, when a patient with degenerative disease requires restoration for maintenance of segmental lordosis, what procedure do you usually perform? Is it A, lateral lumbar interbody fusion, of course, except at L5S1, B, A-lift or O-lift type procedure, C, open laminectomy with posterior lateral fusion alone, D, posterior lumbar interbody fusion via either a posterior direct or foraminal approach, or E, a MIS T-lift, which would simply be a unilateral approach. So when we started using this about 5-6 years ago, we wanted to look critically at our results to ensure that there was a need for this and patients were getting benefit. So we began looking at the cage and doing clinical studies, much of this supported by CoreLink, for which we are appreciative. However, our first part of the study was we looked at our first 12 patients and we wanted to compare these to a age-matched historical control. that used a static cage. And in the second part of the study, we then took a group of patients and prospectively studied their clinical outcomes in addition to the radiologic outcomes. So in the first study, we took 12 patients who underwent open single-level TLIF for the degenerative pathology using the FlexFit 10 in those days. So it allowed 3 millimeters of height and 10 millimeters of lordotic expansion. We measured their preoperative and postoperative parameters up to 6 months, and then compared them to a historical group of age-matched and disease-matched controls who went the same exact procedure, however, in a open banana-shaped peak cage that was static was used. All of these done by a single surgeon. The results we found that we had a superiority in segmental lordosis at that level, approximately 6.5 degrees versus 2 degrees at L4-5 and 7.5 degrees versus loss of lumbar lordosis at L5-S1. And we didn't see in this group at 6 months much of a significant change, although there seemed to be a trend in overall lumbar lordosis. No patients had subsidence in either group of significance. These are our results graphically. Again, you can see the expandable versus static cage in terms of segmental lordosis at 6 months post-op. But most notably, and I think this is going to turn out to be one of the important aspects of expandable cages, is you can see that we were able to use a greater effective cage size in which we compared the static cages to what our pre-expansion cage was. And we're pretty much placing the same size device because we were careful not to oversize the static cage after years of experience with end plate damage and subsidence when trying to place too large a cage. However, once expanded, this gave us a lot greater effective cage size, increasing the foraminal volume and helping us with lordosis restoration. Excuse me. So part 2 of our study more recently was to compare the FlexFit 15 on a clinical level in addition to radiographic results. And this was an IRB-approved prospective study in which we included patients over 18 with degenerative disease of the spine, most of the times with spinal stenosis or spondylolisthesis. All these patients failed typical conservative treatment with BMIs less than 40, and they had none of the usual contraindications. These patients underwent single or 2-level TLIFs with the FlexFit 15 device. Here you can see the typical demographics: half male, half female, age of surgery mean 62, with BMI mean of 31. The usual levels were involved. And what we studied were radiographic parameters, both pre-op and post-op, looking at typical spinal pelvic parameters. We also measured disc height and radiographic fusion status. Clinical parameters followed were oswestry and visual analog for both back and leg. And we also assessed fusion based on radiographic data and need for revision. We collected all post-operative measures at 2 weeks, 3 months, 6 months, 12 months, and 24 months now. And we'll present that data. Typical statistical analysis with the p-value of 0.5 set as statistical significance. Some of the techniques we used for most of these patients were either a mini open approach in which we did a small open single-sided facetectomy and open placement screws on the single side with percutaneous screws on the opposite side. But the majority were open techniques, and many patients had bilateral facetectomies when performed open. We, again, always spend a meticulous amount of time preparing the end plates, performing complete discectomies. We use approximately 4 cubic centimeters of bone packed both dorsal and ventral to the cage. and in all cases had posterolateral fusion with instrumentation. In the mini open approach, they had unilateral posterolateral fusion with bilateral instrumentation. And then you can see a typical patient here. So when we look at the results of the clinical outcomes, as would be expected for most patients undergoing this type of procedure for appropriate degenerative conditions, patients had good improvement in back pain. Up to 24 months, improvement occurred with usually by about 3 months and did not deteriorate after 24 months. Most notably also, they had good improvement of leg pain, and we're always assessing leg pain in these procedures as T-lifts oftentimes have been maligned for resulting in some radicular pain, which we did not see in this cohort. In terms of oswestry, as typical early after surgery, patients have slight increase in their disability, which then rapidly declines. And then by 24 months, these patients seem to be doing quite well. Their disability scores by 6 months have been maintained without statistical significance change by 24 months. In terms of their radiographic parameters, their mean segmental lordosis improved overall by about 6 degrees, which occurred early and was maintained through 24 months. And also the lordosis from a more global L1 through S1 was improved and maintained through 24 months. When we measured disc height, we measured both anterior, posterior, and then took the average, and these parameters also significantly improved right after surgery, and there was no significant deterioration statistically by 24 months, and by 24 months, statistical improvement in these parameters was noted and maintained. So the results of these studies showed that using the FlexFit 15 interbody device in combination with interbody fusion, posterolateral instrumentation and fusion provided these patients with significant improvements in oswestry, VAS back and VAS leg pain, and with improvement statistically in lumbar lordosis, segmental lordosis, and disc height. This improvement occurred at surgery and was for the most part maintained through 2 years. And all patients achieved radiographic fusion at 12 months, and there were no reoperations for pseudoarthrosis by 24 months. No device complications were noted, no subsidence, significant subsidence was seen at 12 months, and again, no radiographic evidence for non-union and no reoperation for non-union. So in conclusion, the use of the Flex 15 device, which is a novel titanium and expandable articulated cage, gave excellent clinical results in terms of disability and pain. Patients had significantly improved segmental and overall lumbar lordosis postoperatively. The cage was inserted easily, which allowed a smaller effective cage to be inserted with a larger effective cage at final outcome. In situ expansion with the interbodies in the interbody space was responsible for this. However, of course, longer term outcome will determine that if we can maintain overall sagittal balance in this degenerative population, and if adjacent segment is at least delayed, if not markedly reduced. Overall, through our use and experience with this cage, we note that it has a greater improvement in segmental lordosis than static cages. The expandable device also gives us this greater effective cage size, allows us to deploy a much smaller device while being placed. We feel that this has significant advantage for clinical outcomes, and it gives us a better end plate contact, a more anatomic fit, better restoration of lordosis, and hopefully reduced damage to the neural elements. Long-term follow-up, of course, is important in looking at how we can maintain overall sagittal balance in this degenerative population. And if by maintaining or improving segmental lordosis, can we delay or reduce adjacent segment change? Of course, further studies will need to be determined to see if this can also be applied in a minimally invasive approach with less ability to perform discectomy and osteotomies. I think that it's been pretty well documented that some of these practical and theoretical advantages are coming to fruition with expandable devices. The peer-reviewed literature had lagged significantly behind the use, but I do think it is now catching up. Of course, we're going to have to further identify what type of cages are most optimal in terms of design, what indication is most optimal, so we can help determine when these are needed. However, I do think it's important always to understand that the mechanical advantages of these cages can be quite significant, and the cage does not provide or it shouldn't replace meticulous surgical technique and carpentry. Can't ask the cage to do too much, especially, which we'll have to discuss in the future in osteoporotic patients. I thank you for your attention. Hopefully you will find this interesting and enlightening. And now I'd like to turn this back to Adam.
Thank you, Dr. Weinstein. That was a very wonderful and enlightening chat. Really great information on not only the surgical aspects, but the clinical aspects with this device. And again, thank you to all the attendees who attended the talk today. We did receive a few questions while you were chatting, so if we can go over those now, if that's all right. So the first one here, Dr. Weinstein, what would you say is the single biggest benefit of this device? And I guess if you could break that out, not only clinically, but surgically as well.
Well, I think the benefit of this device, and the benefit of all expandable cages for the most part, is that it allows you to place an appropriately sized device with the appropriate shape into the intervertebral space in the hopes that you can reduce neural element injury, reduce injury to the end plate, and then restore, or if not, maintain sagittal balance. I think this device in particular, because it's a banana shape, we could place it out anteriorly along the apophyseal ring. And when the cage expands, it expands lordotically, which is the shape we're looking for in the spine. But I think the real key is placing a small device into a space and then doing the increasing of the foraminal volume and the shape of the lordosis actively in situ, rather than just putting in a larger lordotic shaped cage.
Okay, great. Next question we have on the comment of sagittal balance. Why should surgeons consider sagittal balance in addition to just fusion when choosing an implant? And you touched on some of it before, but with this specific implant, obviously the data represented some significant changes, but why specifically this implant do you feel is the best tool for the job?
Yeah, we showed some examples of what happens when degenerative operations fail a patient in maintaining alignment or restoring alignment. And that patient then goes from a degenerative patient to a deformity patient. And so I think that in particular, when we're doing T-lifts, which requires a little bit more effort than some more anterior-based approaches to achieve segmental lordosis, we've got to be very careful not to place the patient in a position where you help them in the short term by decompressing their neural elements and then harm them in the long run by creating a balance problem that results in then yet another surgery and a much bigger operation.
Good. Okay. And then I guess that kind of brings us to our next question. Along with, additional surgeries, are there issues that can happen during the case or post-operatively? With this device, really any expandable, what are your techniques that you use to prevent subsidence when you're preparing and expanding? And, I know you touched right at the end about osteoporosis and osteoporotic bone as a little teaser for next time, but what are your specific techniques with expandables?
Yeah, well, at first we were a little concerned about that problem. I think that problem is, I think the problem of subsidence. I think we need to look at it in two ways. One, I don't like to call it subsidence unless it occurs after surgery. I think that's truly what subsidence is. I think what you see when you're looking at the in the operating room is more of impaction. Now, impaction can lead to subsidence, so we do want to try to reduce that if possible. I do think in very osteoporotic patients, you have to be careful, but I do think if you keep the device along the structural, most important structural aspects of the bone along the apophyseal ring, I think you can reduce that. I think it's helpful that you don't over expand a cage. So, we shouldn't be putting in a 15 millimeter, expanding up to 15 millimeters in a patient that's osteoporotic. So I think you have to have a very controlled and expansion that's appropriate. And then when you're preparing your end plates, I think it's important not to be overly aggressive. So you start shaving at very small increments, and then you increase that. And once it gets to be a fairly tight fit, I think you stop there and then put maybe 1 millimeter less size cage in, and then expand it up 4 millimeters.
Okay, good. And then with the kind of algorithm you just described, I guess just for my own edification, when you're going through the expansion process, have you developed a kind of feel when it comes to the expansion as to what's, enough is enough, and how do you kind of quantify that with your particular patients, right? I mean, you're not just always going for maximum expansion, right? Or are you?
Well, it depends. I think when you're, it requires a little bit of experience with the device you're using. I think when you're preparing the end plates and you're using disc spacers and shavers, you can kind of get a sense of how high you can elevate the end plates. And so, if you know that you can elevate the end plates X millimeters, then I think you can try to place a cage as small as possible with the expansion that's going to give you that. So we generally try to expand the cage fully, because we do think if we're putting in an 8 millimeter cage, that a 12 millimeter disc height is appropriate most of the time. But again, I think with other cages that we've used, it takes time to understand some of the torque involved and how tight it is at your maximal expansion. We usually will snap a quick photo after every few turns to make sure we're not getting impaction. And I think when the end plates are prepared appropriately and the cage is placed in the appropriate structural areas of the disc space, that should be relatively, impaction should be relatively minimal.
Okay, good. So some of that tactile feedback, I guess, that you get during the disc prep, I mean, that's synonymous regardless of whether it's a static or expandable, right? So you're using that to then help, kind of steer you towards where you think you're going to end up with the cage, right?
Sure. And I mean, one of the benefits, the big benefits, and we showed this in graphical format in our study, is that, back in the day, and used to do all your disc prep and determine that it was a 12 millimeter fit was appropriate for the right amount of height to decompress the foramen indirectly and to restore balance of the spine. And then when you took your disc prep out and your shavers out, the space collapsed, and then you had to figure out how to place a cage that was 12 millimeters in the front and maybe 8 millimeters in the back into a space that was now 8 millimeters again. I think that led to end plate damage, and that then led to impaction and subsidence. So that now, by placing an 8 millimeter undeployed device and then doing all the height expansion and lordotic expansion in situ, really reduces the impaction risk, because the end plates are not damaged when the cage is deployed.
Okay, good. Now that kind of ties actually to the next question we have here. So with this particular cage, you have kind of a starting height and a footprint, and you maintain that based on whatever implant you've selected. This next question is that other expandable cages will shrink or change in length during the expansion phase. And so I think to your point, that's by design to help get it into the disc space, but how do you feel that impacts your end plate coverage and, that you can get it positioned anteriorly enough or properly in the disc space?
Well, I think that, yeah. I mean, some of the cages that shrink, it's a little difficult because unless, obviously you have to have a constant force ventral so that it doesn't shrink and come dorsal and then move and migrate in towards the weak portion of the middle of the end plate. I also think that while it's nice to have as much apophyseal ring end plate coverage as possible, I don't know how much intervertebral end plate coverage you want because that takes away room for bone grafting. So, you have to, I think there's an important balance between covering as much as the apophyseal ring to support the distraction of the two end plates, yet still maintaining enough space in the end plate for what's ultimately going to be the fusion, because there is no fusion that goes through titanium or goes through PEEK. It grows onto it, and then of course there are some technologies where it can kind of grow through it, but really we see the best fusions around the cages and all of our fusions, but whether it be cervical, thoracic, or lumbar, the best fusions grow around the device, not really through the little places we pack. So I think it's the design of the cage has to accommodate many, many different factors.
Okay, great. And then the last question we have here, and this is fair warning for our attendees. If you have any more questions, now is the time to get them in. Your last question here, and you were talking about your surgical workflow and how this device could potentially improve that and create some efficiencies. The question here is regarding trialing, and they're saying you mentioned you don't trial as much with the FlexFit 15 device. How do you go about determining the starting height? I think you covered some of this with the last disc.
Yeah, we migrated away from that when we were using static cages. We felt that the trialing sometimes could potentially result in some end plate damage. When we first started using this cage, we would pack the disc space with a lot of bone, and then we felt that maybe sometimes that if you pack too much bone, it would prevent good placement of the cage. So you pack the bone and then you do your trial to kind of create a path. But now again, I think we do all the sizing with the shavers, where we get a sense of how high it can be. Of course, it's always important to look at the other discs in patients to see, compare the anatomy. And so then you kind of have a sense of what size you're going to use. Again, as we have become more and more familiar with this particular device, we tend to use 8, 9 millimeters, very, very popular, static cages using 12, 11, 12, 10. So I think once you start shaving, you kind of get the sense, you take the shaver up into 11 or 12, and your cage is going to expand 4 millimeters. I don't really see the need to place yet another device through the transforaminal space, potentially risking damage to the nerve or the end plate. And we just tend to now pack some bone along the anterior aspect. We then place our cage after the cage is packed, and then we packed a lot of bone dorsal to the cage in between that B area, and then even more dorsal. And I think that gives us a good workflow without having to use a trialing device.
Good. Okay, and then I guess along that workflow question, this is my question here. Does this device change anything in terms of how you decide about kind of rod compression? You mentioned less expulsion risk, but do you do anything different now using this device in terms of when you go to put your rods in and lock those down?
Yeah, I don't think so. I think we're always concerned about lordosis. I think time is going to tell whether we can in patients that have fairly ankylosed spine, if when you're doing it from a minimally invasive approach, if you're not going to do a facetectomy on the other side and really free up the spine to get lordosis, if the cage is going to help us get that lordosis without doing larger procedures. I still think compression posteriorly is very helpful. It helps you create lordosis, especially when you put your cage out anteriorly, which we like to do. I think this cage potentially would retropulse less. I mean, we've not had one retropulse. When you're thinking about putting a single transverse expandable or non-expandable cage, it goes in, and if it comes out, it's going to want to come right back out. Where this kind of cage kind of goes in, swings around, and then stays anteriorly, it's pretty hard to imagine how that can then swing around and come back out the same way with the articulation. So I think retropulsion should be pretty minimal with this cage, and we've seen quite a lot with straight obliquely paced cages. So that's one thing we have noted.
Oh, that's an interesting thought. Good. Okay. And we had one last question come in, which is just asking about your biologics preference and your graft material choice when you're using FlexFit.
Yeah, so in the interbody space, we got away from using BMP many years ago. So what we put in the interbody space is the patient's bone from the laminectomy and facetectomy. And if we need to create a little bit more volume, we'll mix it with allograft, basically cortical bone dust. And that goes in through the funnel into the front. It gets packed in the cage and then goes into the funnel dorsally. And then a posterior lateral fusion, if we have a lot of good bone, we'll just use that for the posterior lateral, but oftentimes we'll mix that with off-label a small BMP sponge on the side that we're doing the T-lift if it's minimally invasive, or actually on the contralateral side the T-lift if it's an open surgery.
Great. All right. Well, I think that's it. There are no more open questions.
Okay.
All right.
Thank you to all of our speakers today for an excellent program. And most importantly, thank you to all of our attendees for participating in this excellent masterclass. On behalf of our sponsor, CoreLink, and today's presenters, be safe and stay well.